Yeah, you mentioned something, and I want to linger here a moment. You said the word access. And I think this is I think maybe a great place to close. A lot of pushback on these new guidelines have said that they feel very elitist. And unfortunately, in our country, we still do have places called food deserts and limited availability of these whole foods, quote, real foods. And unfortunately, those patients can feel like, well, what I'm feeding my family doesn't meet these guidelines, so it might be insufficient. So there could be a lot of shame and guilt and maybe even fear when it comes to that. So how do we kind of let's close this conversation on what do you feel about the limits on access, and how can we help our patients not feel ashamed of what they can feed their patient, feed their family?
Colleen, I'm so glad you brought up this topic, and Viet, you actually started it off. I think when it comes to access, there's like two components to it. There's like the physical access. So is it available at your grocery store, at your farmer's market, wherever you are purchasing your food, and also the financial component to that. So can we afford those foods? We have to keep both of those in mind when it comes to access. And I do agree that that is a challenge, and I like the term you used, Colleen, kind of an elitist approach, because a lot of the food examples that were given, such as we were talking about the inclusion of probiotics and the gut microbiome, and the examples that were provided were things like kimchi and kefir and miso, and these foods. Number one, tend to be more pricey. And number two, they're not readily available in the grocery store. So can we, as clinicians, like be cognizant of that? And if a patient brings up the topic of probiotics and brings up the topic of the gut microbiome, can we then provide recommendations that are more accessible to our patient population? And I think when it comes to that, also we have to keep in mind kind of that cultural sensitivity piece and what is going to be accepted by that population. Many Americans might not have ever heard of kimchi or kefir or miso. They might not be open to trying them. They might not know how to prepare them. So really being sensitive to what might that patient be receptive to eating, be interested in trying, and be willing to incorporate in their diet, I think is really important when we are kind of trying to apply the recommendations that these latest dietary guidelines are including.
Yeah, I appreciate that so much. And I usually, and across everything, including diets, but lipids, exercise, all those things, I always tell people, look, these are the optimal things that we know. And it's not 100%, by the way. If you exercise 150 minutes a week, it's not like you're not going to have a heart attack. It's you're reducing the risk. But I always emphasize quality of life. Like, you do what you can, you put in the fuels that are available, and you choose the better fuels so that you have quality of life that hopefully translates to longevity, but quality in longevity. So for me, it is getting rid of the guilt and saying, look, these are optimal choices, and these are the guidelines are optimized for that, but let's optimize what you have available, and don't feel guilty when you can't, go to the gym every day, or you can't make it to the farmer's market because there's like not one around you. So for me, it's about making sure that we understand as clinicians, as scientists, that okay, the science is there, these are optimized, and now how do we translate that to the individual patient in their community and what's available?